let's run.
No, why are you judging him?
I got it for like a variety of reasons. What do you want to hear? I'll do it. Let's go to Big Daddy. Big Daddy. I like to sit on my side.
I don't know why. I just feel like
And permanent bracelet jewelry wasn't so expensive. I couldn't do that, but it's like now I would do that with it. I don't know about tattoo.
We don't have anything to
what if we all got a smiley face on our
We have the week off.
Next to my planter. Hey, that's.
I would get a smiley face if we got it on the bottom of our face. On the bottom of our face.
No, we can order a sticker code on Amazon. No, not on the bottom of our face.
Yeah, it'll be funny.
I'm gonna get this. Do you think you can give us a deal for 5 cents?
What is our
Say it's like $100 is like
It's not for a while. It's not for a while. It's like sometime in November, I think.
Oh, you want some?
What?
It's crazy. I don't know. It goes away. I don't like it.
And no, the only people that can see it is like your dentist.
She's a wild.
It's the 12th.
It's like a small amount.
It's the 12th. The 12th? Oh my goodness.
Well, we can all go get one and not whatever we get. I'll get one. I want to get the
What?
What should I get?
Y'all go back and watch.
Tell me that would be funny. Imagine even in dentist. And you're like going in there and you just
When I look at this little heart, I hit a copy of it. You can't remember that's without the tattoo.
I didn't know all my life. It's like when I look at my arm, I think about it.
I remember getting the arm. No, I forgot it. I want to get like he jumped up from the corner.
No. No.
Y'all were crushing her dream. Wasn't dead on the side. We had this agreement, and then I said something about the ghost, and then y'all were no. And I'm like, okay, fine. Because I don't want anything to do with like a cringy. Like, I'm not getting sex ghost. I'm not getting. I don't know. I said butterfly.
All right, did they get it right?
No.
Yeah. And this is, like I said, guys, when we talk about nursing priorities, they should kind of be the same, especially with this one. If you didn't put airway on here, you ain't thinking right. So, because C1 through C3, if you're not on the scene and somebody can intubate them immediately, yes, you can back them and get them to the hospital. They're going to die. That destroys the message center. Below C4, C5, you can keep the diaphragm message system, and they can sometimes breathe on their own. So knowing that, if they say, hey, Bubba, he said, hold my beer, hey, y'all watch this. And he jumped off. What kind of accidents during the summer does this come from? A lot of times, diving accidents. Where we like to go swimming, y'all, it's gross. Out in the watering hole in the creek, and everybody's like, ooh, we gonna get off dead man's loop, and jump. And then they got a 5-foot shelf out there where it's 2 inches deep. So they jump out, they hit their head, and they transect their spinal cord. If they say, hey, this is a diving accident, EMS is bringing in, hey, they can't move their arms and legs, what do we probably have? Spinal injury. They should be on the backboard, better be. If you know, you don't even have to specifically have the x-ray and say, ooh, they have a C4 fracture. If they say, hey, they're not moving their arms and legs, they're blinking at me, that's about it, and we had to intubate them. You've probably got a high level. You don't have to know that for sure. But when they start saying, hey, they can't move their arms and legs, what becomes your priorities? Airway breathing. Guys, this stabilization and this airway have to go hand in hand. Because if they can't breathe, or if they're having trouble breathing and it's like a C4 and you don't stabilize it and they have a step-off fracture and then it completely transects your cord, that's bad. Anytime you have a spinal injury, I don't care if you think it's here or here, they need to be on a long spine board with a C-collar on until what? Somebody confirms, and it ain't us, that this patient does not have a spinal fracture. Now, before we get to the other ones, how do you immobilize, and this is in the ER, this is if you were on the floor, this is if Jethro jumped out and you're out there and you have a long spine board, straps, and a C-collar and some other things. How do you completely immobilize this patient? Well, they need C-collar, spine board, and straps. I know straps must be expensive out here because EMS has brought them in packaged pretty as all pretty can be. C-collar, everything. I walk out and I walk back in, and the patient, they have taken their C-collar off and they're laying on the spine board like this. Do you think that is guarding their cervical spine whatsoever? Full spinal immobilization. It has to be midline. If you just got a C-collar on and hey, you just roll his ass off there and now he's on the bed with a C-collar on, it ain't worth a damn. Full spinal immobilization until somebody comes in and blesses this, does the x-ray, says that you can do so much damage with just a little movement. We had a young gentleman in Memphis, we were working in there, him and his friend, 1821, they had been running, and he literally clotheslines himself, like, yeah, and it was the wires, it wasn't a strip, and it like jerked himself off. He got up and they went to wrestling and everything else. 3 days later, man, my neck hurts, y'all. When they got him over to x-ray, radiology called the emergency room doctor, said, I need you and 3 other nurses, a paramedic, and God to get over there and stabilize his C-spine. It was at C3. This was one vertebrae, and that was another one. It's called a step-off fracture. So if you moved good enough, there's the little spinal cord, and it goes right across there, and it cuts it. That's permanent. There ain't no coming back. And I was like, don't breathe, don't sneeze, don't cough, don't poop, don't nothing. He didn't know he had done all that. He's like, my neck hurts. I was like, Jesus was looking after you that day.
You're lucky that's the only thing that's happening.
Right? You know, I never did find out. I mean, as long as they got him up there and kept him still and let him heal, I'm sure they could have done surgery. All right. So we've already said what kind of paralysis is this? Usually they're quadriplegic, which means what? Both arms, both legs. Now, if it's way low, like C6, they might be able to shrug their shoulders, but they're still not going to be able to truly move their arms and legs. What about thoracic spine? What does that mean? From what?
Waist down.
Pretty much the waist down. So what is your thoracic spine pretty much control? Yeah, it's got your trunk. What depends on where our control starts sucking? Where the level of the injury is. So as I go down in the lower thoracics, like T7, I might have more control of my abdominal organs. Does that make sense? Now, there's something that they said 5,000 times, and it's a huge thing on the NCLEX for some reason. T6 and above, all the way up through cervical, is linked to what? Dysfunction. This is a huge thing. Autonomic dysreflexia. Guys, this is a life-threatening emergency, and it doesn't take long to happen. I've got 2 slides specifically devoted to this because for some reason they love it on the NCLEX. But it has to be what? T6 and above. If you got an injury at T12, I guess they've never had that happen. I ain't saying that stuff don't happen that we ain't heard of, but. So, are we just gonna throw airway and breathing out the door? Do we always find out that this is the only injury right at that second? No. There's something else that we didn't add in here. Yes, ABCD. What's big for these people? If you paralyze, skin breakdown, what is that?
Circulation.
It is. What kind of issue is that? Who said it? Safety. Right? Or if I can only control this part of my body, how likely am I to fall out the bed? Because I'm not used to that. Or if I can't, now this is a safety thing for us. If I can't move my arms and legs, what do I have to be self-conscious about as the nurse?
Proper body mechanics, and they can't help you at all.
No, and yes. Guys, how many times y'all ever seen patients you going out the door and they're like, stop! They put their arms out. If their arm is out, they can't feel it, and they can't move it. You're supposed to break their arm. I've seen it happen. It wasn't me. It was not me. No, it was not me. I would claim it if it was. They can't move their arms. And they probably can't feel it much. It still doesn't mean it doesn't hurt. Guys, this is a huge safety thing. They cannot help you at all. And like you said, you're going to have 5 people in there if they're on the heavy side as far as weight goes. Safety does is involved with skin breakdown. It's still a safety thing. They can't move, they can't flip over, and ain't nobody in here that sleeps in the same position for 12 hours. You're gonna wake up and you have a stage 1 pressure ulcer. Lumbar, what's a big thing with your lumbar spine injuries? Bladder and bowel. If anybody has ever, which ones of these are common that we herniate from physical activity or lifting and moving? Lumbar spine. Usually it's L1, and a lot of times it also will cross down into the sacrum. A common assessment they will do, I know this for true, mine's a L5 S1. Every time I would come in, he'd ask me, am I having any problems what? Controlling, because if that happens, it's an immediate surgery. I mean, you can't, that means that something bad has impacted the nerves. Lumbar spine, legs, lower extremities, bladder, and bowel. Here again, there's a whole lot less risk for respiratory complications and the autonomic dysreflexia. I have seen autonomic dysreflexia one time in 28 years, and we didn't even know that's what it was at first. His blood pressure got to 310 over 180. And over the span of like less than 8 minutes. It's quick. We just talked about this. What determines the signs and symptoms? Where it is, the level, and even that, even if it is, yes, where it is, cervical, thoracic, or lumbar, but then you can go ahead and break that on down. Where is it in the cervical spine? At what level? Because it makes a difference. This is what we just wrote on the board. Now I'm sure y'all have figured out by now what this global looks like means, right? So this is kind of an all-encompassing umbrella. This is online now. This should be your PowerPoint. This is very important. Wink, wink. Years ago, before they put the shock into 5 different things, we had 18,000 different kinds. You had spinal shock, burn shock, brain shock, hypoglycemic, like I'm serious, hypoglycemic shock, and I'm like, Jesus Christ, I can't remember all this. There's a reason we did not cover spinal shock. It's not truly a shock. I know they list that. Neurogenic shock is the one that follows all the rest of them. You got anaerobic, you got this. But the only difference was there was a transection in the message system. None of the other shocks had that, right? The difference between a spinal cord injury and neurogenic shock is the second this happens, that primary injury, you have flaccid paralysis below the level of injury. Does that define neurogenic shock? What is neurogenic shock? What happens?
It's the miscommunication.
Bradycardia? What'd you say?
It's like the miscommunication, the message.
There's a horrible discommunication between your sympathetic and parasympathetic systems. In fact, your sympathetic just gets shut out. Parasympathetic kicks in, so we've got bradycardia, hypotension, you're going to go to sleep type signs and symptoms. Warm, dry skin. It doesn't fit any other shock. Guys, if I'm testing y'all on TBI and SCI, I ain't going to give you a question about septic shock. Right? So all you need to know is the signs and symptoms for neurogenic shock. And if I say, hey, patient A, B, and C was diving off the bridge, and now they come in with quadriplegia, and they've got all these other things, what do you suspect? Spinal shock or neurogenic shock? Did I say anything about hypotension, bradycardia? No, it is a thing. I don't know why they call it spinal shock, because it doesn't really fall in. There's no hypoperfusion. It is just called, it's a shock to the system, the spinal system, because it does it always completely transect the cord? No. So what causes that paralysis below the level if it's not cut? Swelling. How many days does it take that swelling to start going down? Usually it's about 3. You won't see them make any harsh judgments calls within the first 48 to 72 hours. We need to let the swelling go down, right? Now after a week, if we haven't had any change, the swelling has gone down. That's when some of the difficult conversations start. How do we test motor function? Grips. I did it that day, right? Squeeze my fingers. Move your, or if you can't even do that, hey, pick your leg up, pick your leg up. Give me a thumbs up, you know, that kind of thing, so they can follow commands and they can move everything. The word sensation, we always think touch, but is it just touch? It's not. And it is, you know, when you go to the doctor and they say, can you feel this? Can you feel this? Now, don't let them keep their eyes open. Can you see me touching you right here? No. But what about pain? That's a whole different thing than touch. And once you've had an injury, you might have numbness to that area. I can't really feel that. Now, if you come up and hit that, it hurts. So I've lost the sensation of touch, but not pain. What is this? proprioception.
Is it how you balance?
It's kind of figuring out where we are in relation to everything else. So this is what keeps me from just walking up and falling all over him, because I know, I mean, I've got to have my eyes open, but I know he's here. If you've had an injury that affects that, I can't gauge where the distance is. You just might be walking and there's the edge of the building. So you don't have that sensation anymore. Temperature. Depending on where this injury is, bowel and bladder. What's this? This is long term. It is muscle spasms. And I know that sounds stupid if you've got paralysis or you can't move something. Those muscles can still spasm. Guys, how bad do sometimes muscle spasms hurt? Can you imagine having that Charlie horse for the next 20 years? So if I'm not moving, what else happens? Contractures. Once that contracture comes up and the ligaments and tendons, basically they're not being moved, so they basically draw up. It can be in any joint. You'll see them in their legs. Their legs will be pulled up. Their arms will be pulled up. Their fingers will be pulled up. Once it gets to this, can you straighten that out? You can. You'll break their fingers. Whose fault is this? Ours. Guys, it's really hard if you have a quadriplegic that's in there in a long-term care for them not to get this. I ain't throwing shame. This is our fault, not just our fault. Wherever they're at, the CNAs, the techs, the nurses, they have got to have passive movement. It still might happen a little bit, but if you come in and they like this, that ain't all just it happened, even though we were doing our best effort. Once they get the contractures, there's nothing you can do. I don't even know if you could do. You'd have to break the bone. Is that gonna do any good? They still can't move it. Our airway assessment. Is their airway open? Can they follow commands? Are they even breathing? When you do your airway assessment, if it is a spinal injury that you're suspecting, it needs to go into your mind early. Do I need to intubate them? Do I need to give them advanced airway? Or at the minimum, do I need to bag them because they're not breathing adequately? Above C3, C4, and C5, you might what? You might need to intubate them. They do not have any control of the diaphragm. I never realized how important your diaphragm is in breathing, but if you don't have those nerves innervated, you cannot breathe. What is this talking about? I'm doing my assessment, and I see bradycardia and hypotension. What am I leaning towards? Neurogenic shock. You're still going to do your motory sensory. Guys, we don't focus so much on reflexes. I'll be honest, I don't even know how to use that little reflex hammer. I never could get it. I always felt like an idiot. I'm like. But if they're not breathing, is this important? If y'all stand out there, y'all reflex hammer, but they ain't breathing, you need to come back and see me. And this is down in the level of importance. If I've only seen this at Vandy, they called it the Vanderbilt handshake for some reason. If a person comes in and we suspect spinal injury and they're not moving arms and legs, they're supposed to put KY on their finger. Why? If they have sphincter control. If they do not, that is not a good sign. And if they faking, they realize real quick they don't want them to do that again. I've never done it, but the first time I saw it, I asked him, I was like, why did you do that? And he said, I mean, who in here has either given a suppository or whatever, you put the suppository in and it just goes right up, and the anal sphincter grips the pill and pulls it up. If they have a spinal injury that's high like that, they can't move their arms and legs, there's nothing. He said there is no sphincter tone.
I have a question.
Yeah.
So, is a spinal cord injury is a difference from your shock, or is it the same?
One can lead to the other, but neurogenic shock is not the same thing as spinal shock. Spinal shock is the injury, flaccid paralysis. Like I said, I wish they didn't even call it that, but I can't say we ain't gonna call it that because that's what they call it in the book. These are just global interventions. So the two words that need to go along with any spinal cord injury is immobilize and stabilize. Cervical collar. You're still going to do your initial assessment, your ABC. What's the D here? It is disability. So A&O times what? But what factors into this one that you might not have done with other patients? That's really important. Pulse, motor, sensory. I don't do that on everybody that just has an altered level of consciousness, right? Vital signs, pain assessment. I'm looking for signs and symptoms of complications, i.e. respiratory failure. Different types of pain feel different. Do you understand what I'm telling you? If anybody has ever had nerve pain, has anybody in here I ain't trying to throw y'all out. Have you had nerve pain? What did it feel like?
Like burning.
Burning.
And it was like continuous.
Tingling. Anybody else? It feels like an electrical current. It is not a deep, it's not a not generalized, like you can say, hey, that runs all the way down my arms and right here to my pinkies, right? What about like anything that's in your abdomen? Like if you got just generalized gastritis or whatever, you can't say it's right here. It's more of a dull ache, diffuse. Chest pain, cardiac. It's very localized. It can be referred, radiating, right? But it's pretty much right here. The solid organs like your liver, even your appendix, your gallbladder, they can't just say, oh my God, it's right there. I know you do the rebound tenderness on your appendix, but it's not burning. It's not that electrical current. I've heard people say it felt like, if you grew up out in the country and we played that trick on y'all, you grab the electrical fence and it goes down that. If anybody's ever been around anybody that has shingles, how did they describe it? It felt like there's an electrical current. Shingles sits on a nerve tract and is extraordinarily painful. I hope I don't ever get it. That's how, I mean, you're going to ask them the questions on set. What does it feel like? Because that really does put something in your mind about what sort of pain this is. Have y'all ever heard the word dermatome? What does that mean to you?
Shows the areas where the spine touches the colors.
I never knew how accurate that is. And everybody can look up a little picture of the dermatomes and it's got specific areas. Stop it. And this is important. Now, you ain't, if they ain't breathing, you ain't gonna do this. But, hey, let me look that up real quick. So, C3, C4, C5. And guys, it is exact. But you notice it stops right there, and then it starts right here. When I worked for Lifelike, I didn't know that degenerative disc was so bad. I started having shoulder pain. I pulled in the seat out of the aircraft and thought I had torn my brachial muscle. Went to the emergency room. They're like, "This sucks. We don't know what's wrong." Finally went to get an MRI 6 months later, and I had spinal cord impingement. I keep going to PT. I was like, "Oh my God, my forearm hurts so freaking bad." That's exactly where it was hurting. I have a triple level fusion, C3, C4, C4, C5, C5, C6. And look, I could draw you a line where it hurt and where every electrical circuit pain went down. C6, thumb, C8, it never hurt there. Like I took my pen and drew on here for my neurosurgeon. He walked in, looked at that, and he said, "When do you want to have surgery?" I said, "Next week." Because I was miserable. Guys, this makes you miserable. That comes to the point. We listed all this. What have we not talked about? Who said it? Psychological. If I'm a marathon runner and I'm doing what's the one where you swim? The triathlon, bike, run, I would die the first 5 seconds. When I was swimming, I fell off something and I have a spinal cord and now I'm a quadriplegic and I've got all these awards for running all these marathons and I'm 30. How devastating is that going to be to me? This is not a sexist comment. What if I'm male?
Suicide risk.
Why? Pretty much, their stuff don't work. Now, I'm not discarding his wife. What just changed for her? She wanted a family. Can you still have one?
Yeah.
But what are they going to have to do?
Adopt.
They're going to have to go in and retrieve his sperm. Guys, I'm not a guy. I cannot even fathom. I mean, and let's be honest too, A, B, C, D, S is down there with sexy time. Physical touch, you can't feel anything anymore. And you can't provide your wife with the only dream she's ever had. Right? Now, you know, I'm just guessing. I've never thought about this. So if it's the woman, this is going to sound bad. She just has to lay there. But does she still? But I mean, you see what I'm saying? She still is going to ovulate. I mean, but can? Stop it. That's what I said. I'm so confused. Like, she would feel contractions, or would she? We need to look that. Does anybody know? I mean,
They can take the carry monitor and see the contractions on the monitor and tell them to push.
They have to wonder
It makes
Yes,
a
ma'am.
difference.
Hang on, guys.
What? There's criminal cases where there's somebody that did a state that was assaulted. The sitter actually had raped pretty much the current legislation, and then she had a baby. Yeah, she was a comatose, and then she had a baby. And then they found out it was a
That it was basically a patient that was probably at a rehab, skilled nursing facility, a nursing home that wound up pregnant. Like, really? You can't say she was willing. So I mean, I guess that the wife still could get pregnant, but why can't the man do that? He's got to have an erection, he's got to have ejaculation, and depending on the level, yes ma'am.
There's shots. I saw this on TikTok. Like you can actually like.
I know exactly what you're talking about. That dude in the wheelchair. I know what you're talking
Now.
about.
And he showed the chair.
Yeah, he showed the
I know we're laughing about this. this, but it does depend on the level of the injury because, and I had to look this up to make sure I said this right. So, hang on. The level of spinal cord injury that can lead to erectile dysfunction depends on the specific area. T11 and below can usually experience psychogenic erections, which are erections that can be arousing sight, sounds, or thoughts. S2, S4 are unable to achieve reflex erections, which is the physical touch. Above T11, they usually cannot experience psychogenic erections because the message is not there. So it all depends, it seems to depend on where the level of the injury is. I mean, and this would be really bad for the guy if he couldn't feel it but could still have an erection, then you could have a child. And there are things that I've heard, like the nerve stimulators, it's something along those lines in that area that can help them. Because like I said, I mean, guys, some people, that's all they've ever wanted is a family. And collectively, it wasn't like he was saying, I don't want no children, I'm going to go jump off a bridge.
Is there like no way to like go in and get sperm?
There is, and that's what we were saying. But I mean, might that sometimes not work? I mean, there ain't anything as good as the old-fashioned way because you're going to go in and retrieve it, you got to wash it, you got to inject it in the female. And what else is involved in that? Money. That's expensive. It's expensive to retrieve eggs. It's a lot more expensive to retrieve eggs than it is sperm. But, what?
You said it's easier to achieve.
There you go. Old-fashioned. Cervical spine. Why have I got this little no sign over there for him running? He ain't gonna be running no more. They are quadriplegic. Can't move, can't run. For a injury from C1 to C3, it is critical that you look at what? Airway. They will not be breathing. They cannot breathe. C1 through C3 is a complete loss of respiratory function. So I have to ask y'all this because I was wondering about this morning. This has nothing to do with this. I just looked at my PowerPoint. When y'all download my PowerPoint, can you see my notes?
Yep.
Yes.
Because one of the other instructors, yeah, you have to download it though, right?
Yeah.
Because one of the other instructors like, no, if you download it without your notes, if I was like, I'm gonna be lying to you. Yeah, and well, I don't know how you do that. Then I mean, I don't care. As long as like y'all ain't. So you'll notice that I added some. And I did that on purpose because I don't want y'all reading me the answers when we come in here. I didn't change the PowerPoint per se, I just added a lot more notes. C1 through C3, you can just tell them it's going to affect their respiratory system. They're going to require mechanical ventilation. Here again, spinal injury or spinal shock, if that, I'm going to stop saying that word. Flaccid paralysis below the level of injury. I didn't say hypotension, bradycardia. But can spinal injury lead to neurogenic shock? It can. But neurogenic shock doesn't lead to spinal injury. Does that make sense? I think one of the questions I gave you guys, the case scenarios in the shock was a gentleman got thrown out in the car or on the motorcycle, and they get there, and heart rate's this, bradycardia, whatever. Now, what did he might have done? He might have hurt his spinal cord. He might have had a traumatic brain injury. Doesn't matter. He's in neurogenic shock. I didn't say they got there, his blood pressure was 120/80, heart rate's 110, can't move from his neck down. Is that neurogenic shock? It is not. Just don't get those two confused. All you need to do with spinal flaccid paralysis, all you need to do with neurogenic shock, it's shock. There is no perfusion going on. Now, if I've got a spinal injury and it starts swelling, what's that going to affect? Your perfusion. C4, C5. If it's a higher, like more towards C4, they may still be having a lot of time breathing. C4, they might can move their shoulders. Remember I said it might not completely be all the way down. If you come down further in the cervical, they might be able to move a little bit of the upper of their upper arms, but there's not a whole lot other than that. You're just going to lose all of that. It does say that if you get down around C8, they might have some hand function. I cannot remember. It's an older movie with Denzel Washington and Angelina Jolie in it. He was a paraplegic, but he had movement in one hand or something like that. Something bone collector. I'm telling you this for a reason. He had, I'm gonna have to download that video now. He had an episode of autonomic dysreflexia, breaks out, diaphoresis. It starts, his blood pressure starts going up. I just thought about that. So it's a really good example of that. C3, C4, C5, keep the diaphragm alive. So if you have an injury, heaven forbid, above that, they're not going to be breathing. Complications, respiratory failure, autonomic dysregulation. What does that say? High risk for developing neurogenic shock. What is your thoracic spine control? That sounds like the campus-wide alarm thing. I'm like, you gonna be running? Run. Your abdominal organs, your legs, bladder. This is the uterus, but I couldn't put male's picture up there. I figured I'd get kicked out. But we just talked about it. Depends on where the injury is, whether it affects the genitalia of the young men. If you think thoracic spine, T, it affects the trunk. So the lower down the injury is, how does that affect my control? The higher up, how much control I got? Not a lot. Lower down, I would have more. And that's the way this works. If you think about cervical spine, if the injury's at C2, how much airway control do I got? None. C5, I might be okay. It's the same thing. The higher up you come, the worse this gets. The lower down in the thoracic spine the injury is, you might have control over A, B, and C. You might have control over these abdominal organs. You see what I'm telling you? It's the same thing for lumbar spine. The lower down you go, the less of an effect it might have on the legs, the lower extremities, bladder and bowel. That's why he kept asking me, because mine was the L5-S1. That shouldn't have affected my bladder and bowel. Now, can you have a herniation above that level? Yes, you can. You got some hairy legs. I hope that ain't one. A lot of times thoracic, especially depending on at the higher level, they're going to be a paraplegic. This means what? They can't move their legs. Guys, is this still a safety risk? It is. They can still fall. Skin breakdown is huge. But now, can they help you with moving around? Yes. And they need to do that for their physical health and what else? Their mental health. They need to do as much as they can by themselves. This has altered their life. and it usually affects their pelvic organs. T1 through T6 is the trunk. What's the big deal about above T6? Autonomic dysreflexia. Guys, that is life-threatening and it can kill people. 7 through 12. Abdominal muscles. What does your trunk do? What's it good for? Balance. If I didn't have this, I'd just be a bag of bones, right? It's what helps us to stand upright. I know all our muscles do. I know you find it. That's fine. So if I don't have control of any of this, my posture is gone. But if I do, then I can at least stand halfway upright or sit upright. I'm not standing. And it just affects the lower abdominal organs in the pelvis. The lower the injury, honestly, the better the outcome. The further up the injury, the more likely that you're going to have complications. They usually do not have impaired respiratory function, but you cannot just throw it out. It can still lead to neurogenic shock, especially the higher level injuries. All right, we're going to talk about this. Autonomic dysreflexia. What does the word noxious mean to you? The way I always remember this, they being obnoxious. What does that mean? Getting on your last nerve. This spinal cord, did you get on your last nerve? Noxious. Physically harmful or destructive to living beings. And yes, I did the Wikipedia this morning. Because I was kind of like, what noxious stimuli is. But it's not necessarily something that me or you would say, hey, this is terrible, awful. My tie's too tight. Does that normally make us pass out and stop breathing and blood pressure? No. It can them. This is something that either puts pressure or kind of disrupts circulation. Not bad, just a little. What did I just say? Necktie. What else? Socks. What am I touching? I don't want y'all looking at me necessarily, but your belt, socks, belt, tie. Yes, ma'am.
Could it even be like bracelets?
Bracelets, wrist, rings. What else?
IV tourniquet.
Heaven forbid, IV tourniquet.
Could be like restricted.
Yes. Down to it. Guys, we don't really know why this happens. But is it important that I figure out what is causing this? You might only have like 6 minutes. If you can't, girl, they're going to be naked and not touching nothing by the time I get done with it. I mean, because what if it's their brain? It can also be something that's pressing real hard against the skin. Like if they don't really have any control over it and they're laying up against the bed and it's pushing. Anybody in there had to pee really bad? I mean, it gets to hurting at one point. That is the biggest trigger for this. Now, what does the thoracic spine control? Ladder. They don't know that it's full. How might you tell? Guys, if it gets that bad, you can feel it. You might can see it. But at the end of the day, if this is happening and you can't find anything else, what you gonna do? We fixing to do a straight calf. Okay, that wasn't it. Okay, no harm, no foul. At least you didn't die. I mean, I'm serious. You have got to figure, and if you've gone through everything else and you're going to be hollering, hey, go get me a straight calf. I don't even care if you put a Foley calf in at this point. You have got to make sure. Now, if it's not their bladder, what might it be? might be their bowel. Now, if it's an upper level impaction, you can't figure that out. But how can you figure out if it's lower?
Disinfection.
Guys are gonna die. You need to get over it. You ain't found nothing else out. And what if you put your finger up there and you can't even get it in because they're so impacted? It's still creating pressure in their abdomen. I did not know that. If you look down in my notes, it says triggers: bladder distension, bowel distension, skin irritation, pressure ulcers, tight clothing, or burns, pain, fractures, or even sexual activity. I don't know what happened there, unconscious.
What word is that?
It don't say a little bit. And you know that's how we word these tests. It can't just say it's 130 over 79. Up to 300 systolic. This is key as well. They don't describe it as a band. It is a throbbing, or why does their head hurt because their blood pressure is, oh my God, over 300. Why are they getting bradycardic? What do you think's happening? They're going into neurogenic shock. And so what happens in neurogenic shock? Parasympathetic and sympathetic and all that don't start work. It stops working like it's supposed to. They're going to get hypotensive. They're going to get bradycardic if you don't stop this. I don't know why. This is a huge sign and symptom of this. So if you walk in and their blood pressure is, oh my God, they got a spinal injury, and they say, I can't breathe, my nose is so congested, you need to do something, this might be important. Because it is a hallmark sign and symptom of autonomic dysrhythmia. I have no idea why nasal congestion. But it ain't up to us to figure out why on that. You've got to find the cause. Take their belt off. Look to see if they've got tight socks on, a tight shirt. And as you go down through this, you might have to think about doing the in and out calf or determine if they have a fecal impaction. What is your lumbar spine control? Basically your legs and your bladder. L1 and L2 is dealing with more what? Your legs. Hip flexors, lower legs, may still retain some function in the thighs. How good do you think they're going to be walking or standing? So I told that surgeon when I herniated, and I was on paramedic clinicals the day I herniated it. I was trying to pull a guy out of the car. I told him, I said, you're not doing surgery on me. I'm 27 until I can't walk. About a year later, I about couldn't walk. And I couldn't do my job anymore. He came in and he said, you can either keep being stubborn, you're developing drop foot. What does that mean? Why was it doing that? It was a lower level injury, but what's being affected? The muscles and movement of my leg. And so I was like, okay, when we have surgery, and I had it on December the 21st. That was a sucky Christmas. But that was a year later. It's still a complication that you need to be aware of. This is usually not linked to respiratory complications. If you have multi-system trauma and you're like, oh, it's just lumbar, don't ever rule everything else out. But if they're not breathing, this is probably not the problem. These three are critical complications of spinal injury. Spinal shock, it is a type of shock, but we don't talk about it because it's only linked to spinal injury and it doesn't really affect your perfusion unless it goes where? Here. Why does neurogenic shock affect your perfusion? Causes massive what? Vasodilation. They basically become hypovolemic, right? You ain't got nothing. Your pipes have gone great big. You affected the container. You got the same amount of liquid. Your blood pressure has gone down. Cardiac output has gone down. That's your perfusion. Spinal injury doesn't cause that. You just got paralysis and autonomic dysreflexia. These are the emergencies. The only reason I put this up here is because it just confuses people. I just want you to remember, spinal shock, immediate temporary loss of total power, sensation, reflexes below the level of injury. If they've got hypotension, bradycardia, it's neurogenic shock. This is a sympathetic, parasympathetic. There's no messages going on. This is due to injury. Oh, I didn't even think about this. Your blood pressure cuff. Somebody said tourniquet. Who said that? Yeah, and so, I mean, I thought about that, but because how often do them freaking blood pressure cuffs? I mean, they annoying at best for anybody that doesn't have a spinal injury. The first thing you need to do when you walk in, because bladder distension is the #1 trigger. This is important. Knowing that was the first thing you're going to assess. Make sure their bladder's not distended. I'm not saying you ain't going to start ripping clothes off too and make sure they don't have a belt on. If they have a Foley in, what are you going to immediately inspect? Is it obstructed? Is it kinked? Because that does what? It can't come out. Remove constrictive clothing. Now, if you walked in and it's a T1 injury, which is where? It's like right in here. Blood pressure is 360 over 180. And somebody yells, hey, go get the metoprolol. And you run and get it. You gonna give it? No. Is that the problem? If you don't take care of the trigger, is it gonna work? It will not. Might this much don't count when it's 350 over dead. You are doing your assessment and you are intervening on what is causing the problem. Now, in normal circumstances, if the doctor said, hey, go give that patient down there in room 7 labetalol, and you go down, you do your assessment, the heart rate's like 160, blood pressure's up, will you give that? You will. That's linked to their cardiac. This is not linked to a spinal injury. You're not treating the cause. You're trying to treat the fallout, and it's not even going to work. That's just a picture. This is not a lot of material. What is the most important thing to remember about this locally? Where is what? The level of the injury. That tells you pretty much everything. Because I'm not going to go in there and say, if you got an injury at T5, what is going to be the specific sign? No, that's not fair. But I need you to know what's involved with your cervical spine. The big complications, airway, thoracic spine, the big complications, and autonomic dysreflexia. Now, I said T6 and above, right? If you got a C3 fracture, can you have that? Yes, you can. It didn't just say T6 to T1. And then it stops. This PowerPoint is on there. That study guide is on there. I also put the study guide for traumatic brain injury from the other day and the recording. Did we get through all the slides on TBI? What's left?
The bull hole.
Burr hole, okay. Okay. There's only like 3 slides. Alright, what did I tell you was important about, besides their imaging? What is this? It's the epidural hematoma, right? What are the characteristics of this? It is both of them are bad, but this one is the absolute emergency. Because the subdural can be what? Chronic. And it's been 7 days since I fell. Both of them can kill you. This one can kill you very, very fast. What is a characteristic of this one that that one doesn't have? Short period, you lose consciousness, you come back, you're kind of with it. The next time you go out, there ain't no other lucid period. And that means it is an epidural. This is 95% of the time. I've never heard of one that was venous. This is the artery. If you got a catastrophic bleed, where are you bleeding from? An artery. Subarachnoid. What's a hallmark sign of that? The worst headache of my life. It came on like a thundercloud. The biggest thing that we have got to do is treat the cause. If I have too much cerebrospinal fluid, how do I treat that?
Drain it.
You're going to put a drain in and drain it out. I told you you can put that in and you can drain so much amount. So if you've got an EVD in, you're also monitoring the pressure, right? So you know how much to drain out. I mean, you ain't just going to go in there and flip it open and be like, hey, y'all. What if you've got a hemorrhage? Elevate the head of the bed, 90 degrees, right? No. Patient positioning. Decrease that intracranial pressure however you can, keeping the body midline. Keep their body temperature down. Treat seizures. How much metabolism does seizures take? It increases that by like 200%. Reduce stimuli. Anything to bring that oxygen consumption, the metabolism down. CSF fluid, surgery, and a drain. What if the problem is in my brain itself? My brain is swelling. What? Give it space. How do I give it space? Or get it halfway back to its normal size? Give them a diuretic or a hypertonic solution. It's got too much water up there. I want to do what? I want to pull it out and let them pee it out. These are the different surgeries. They might do a craniotomy. They remove part of the skull. A craniectomy is really hard. Remember we talked about linear and comminuted? It's just crushed. and there's all these little pieces of bone in there. That's hard for them to treat. They might do a cranioplasty where they repair the damaged skull. What's a burr hole? I think we talked about this. They just go get the Black & Decker, not really, and drill a hole. I mean, I swear that's what it looked like. I don't know where they did it in the emergency room. I mean, this was last ditch effort. And you put a hole to relieve the pressure. Does it always work? No, because what might start coming out that hole? Their brain. What does this mean? There's nothing we can do. And if you did do that burr hole and their brain starts coming out, do you think there's anything we can do at that? No. Right? You give them a blanket. But you still, we don't just say, oh, well, that's it, and walk out of the room. You still try to do everything you can. You would still give them medicines to not let them what? Seize. You don't want them to be in pain. Just because we know they're going to die doesn't mean you just stop everything. That is a picture of a burr hole. Trying to relieve that pressure. So there's something else they can do if they are bleeding. Because when we bleed, what does our body form? A clot. Sometimes it is possible for them to go in and remove that clot. Not just because it occupies space, but evidently blood itself is very, very, very irritating to the brain. Does anybody know the best way to get somebody to throw up that has a nosebleed? Your stomach does not like blood. If you want to see somebody throw up and they got a blood, yeah, lean back like this and pinch your nose. It's going to be a few minutes. It is so irritating to the stomach. It is the stomach, oh, I don't like this, and you're going to throw up. It seems to be the same thing for the brain. They say it's very irritating to the cerebral tissue. Those were the only ones that we didn't cover, right? It's the very last ones. Any questions about the before this? What is and I heard somebody say a minute ago, this is a lot of material. It kind of is. What is the most important thing to remember about both of these? You need to understand the big picture, the concept. Everything goes back to the Monroe-Kelly doctrine. Whether you've got a hemorrhage, whether you got too much CSF, whether you've got a space-occupying lesion, it doesn't matter. It goes back to those three things. It's affecting something. Well, they went into neurogenic shock. That's because this, that, and that happened. If you know that their brain is swelling, you know what to do about it, right? Y'all definitely make sure and go and look back at the GCS. I told you I'll give you the table, and I'm not going to try to trick you with that. And guys, once you get out, guess what I carry it in my pocket all the time? I can't remember that. I mean, I can remember some of it, but not all the numbers. I know if it's a 6, it's bad, and if it's a 15, it's pretty good. And it is. You either have a badge buddy or a flip guide. So if you had somebody whose GCS was 15 and 10 and 6, what's happening? They're declining. And even before 6, let's say 15, 12, 10. I need to start thinking what? We need to intubate them. That's not, like if you said 15 and 13, I'm not so concerned, but I'm not just going to, I'm going to go back in there shortly after that and see if we have declined or were they just sleeping. It's very important to look at the trends for these patients. Any other questions? What's the first sign and symptom of increasing intracranial pressure? Altered level of consciousness, i.e. anxiety or apprehension or restlessness, irritability, yelling at you. Me on a regular day.